then I think we should now answer the question of patient selection. So thank you once again, Emmanuel, for your presentation. And now we go to the patient selection question. And we already discussed it, that it's really important to have a really proper patient selection. And it is always the question how we should select the patients, what examinations are necessary. And Professor Hübner from Vienna, I'm quite sure he will answer for us this question really perfectly, and he will share especially his great experience with us. So thank you for sharing your experience, and we're really happy to have you here. Thank you.
Colleagues and friends, I will, Emmanuel showed us all the different systems we have available now, and it will be my task to share some considerations as to how to decide between them. So the things used to be pretty easy in the past. We had bulking agents, and we had an artificial sphincter, which was a little bit an adventure in the old days to implant the sphincter, and the bulking agents didn't really work. And now we have a ton of different implants, and we already discussed that it might be a little bit difficult to find out what to use. It became much more complex, but we can better work for our patients with these implants. Now, if we have a look into the EAU guidelines, and Emmanuel already showed it, it is not very helpful, I must say, if we have patients who desire only temporary relief of their incontinence. You can use bulking agents. If you have patients with mild to moderate, you can offer fixed slings. If you have moderate to severe, you should offer an AUS. If you implant an AUS or a PROACT, it should be in expert centers, but this still does not help us very much with the decision, and the grade of recommendation is pretty weak anyway. So, and the adjustable slings, which were in the question, in the first question discussion, where they are not even mentioned here. So what can we do? Let's have a look into the pathophysiology of things. The reason for the post-prostatectomy incontinence, and this is what we are mainly talking about, not the neurogenic patients, is a bladder dysfunction due to overactivity because of the manipulations on the bladder neck and the innervation. Of course, there's a direct trauma to the urethra and the sphincter region, resulting in ISD. And then, last but not least, we have the trauma to the neurovascular bundle. And this should be the main reason in most cases. Now, if we look at the etiology, the bladder probably does not play the big role, but in most cases you will have an ISD alone or in combination with the bladder disturbance. So for our diagnostics, it's important to distinguish: do we have an impairment of the neurovascular bundle innervation, or do we have a real structural sphincter damage due to fibrosis? Now, looking into the clinical facts for male incontinence, many patients who are incontinent would not even leak when they cough. And some of these patients can definitely interrupt their stream. So, and these patients get worse in the afternoon. So what does this tell us? It tells us that the striated muscle is intact. The pelvic floor is intact, but still the patient is leaking. He is leaking because of a problem with his baseline incontinence, okay? So this is not really a big surprise, because the striated muscle of the pelvic floor is working due to the fact that the pudendal nerve usually is not at risk during the surgery, but very much so is the innervation of the inner sphincter, or the autonomous sphincter, or the smooth muscle sphincter. And for me, I really prefer to distinguish sphincter-wise between a smooth sphincter part and the striated sphincter part, and not so much between the internal and external sphincter. So what are the capabilities of these muscles? If you look at the smooth muscle, it can contract on a long-term basis. It can permanently contract, but not very strong. It only contracts by 10 to 15 centimeters of water. On the other hand, the striated muscle from the pelvic floor can contract very strong, up to 100 and 150 centimeters of water, in order to resist intra-abdominal pressures of that height. Now, if we have an impaired smooth muscle caused by neurovascular bundle trauma, but the striated muscle is intact, which you can find clinically by interruption of the stream, you sometimes only need to raise the urethral resistance by 10 to 15 centimeters of water. And this can be done by slings of all kinds and the ProAct. If you have a fibrotic sphincter, that means that there is no contraction, even not with a striated muscle, a real fibrosis, you will need more than only the 10 centimeters of water. That means you need the closure pressure of a hydraulic sphincter, which is usually between 70 to 90 centimeters of water. And you will need this real closure, but also, of course, the open mechanism. That means you need an AUS. It is important to understand that the quality of the incontinence does not necessarily have anything to do with the amount leaking. You can have patients that leak 500 cc's of urine every day, but still they can interrupt the stream. So it is important to understand, are we dealing with a striated muscle problem or with a smooth muscle problem? So the key factor, in fact, is the impairment of the sphincter, either fibrosis or neurovascular bundle trauma. There are other factors like hypermobility or urethral blood flow, but in fact, we will not touch this topic. It will get too complicated, and the key factor is the sphincter itself. Now, what is the basis of our decision-making in male incontinence? Of course, we need to know the grade of incontinence, the amount leaking every day. As I said, I want to know, can he interrupt his stream? And we need to know things about previous operations. Patients, we say, sometimes have 2, 3, or even more operations already in their sphincter region. Then you want to know something about the urethral condition, a history of irradiation, of course, and the sphincteric function that you might check out with an elevation test. If you're looking into an AUS, as already mentioned, you want to know something about the mental status and the manual capability. Looking into slings, you should know something about the detrusor function. And of course, you need to see the patient in his overall condition. And as Emmanuel already mentioned, you need to know something about his attitude and his expectations, what he wants to do once he's dry. Most of these informations you can get with a history, the 24-hour test, definitely with a cystoscopy, a uroflowmetry, and you will take some residual urine, I guess. And with these informations, you can make a pre-selection already. But this should be followed by a specific evaluation, as I mentioned, by an elevation test, retrograde leak point pressure, a clock test or a ball pen test before you implant an AUS to make sure the patient will be able to use it, and so on. when you have this information, then you can decide between the methods that we have available, the adjustable balloons, fixed retrourethral slings, adjustable slings, and hydraulic sphincters. And these four methods, as Emmanuel already told us, really work in different ways. Now, they work in different ways, but what are the characteristics that you need to make a decision which one to use? The adjustable balloons are located above the pelvic floor. That means if there is irradiation, they're completely in the irradiation field. Therefore, they are contraindicated because they usually erode into the bladder or the urethra. The PROAC balloons increase the urethral resistance. There is a certain amount of elevation even of the bladder neck, and they are really minimally invasive. You could do it under local. However, you have sometimes a delayed result because on average you have to have 3 adjustments with 4 weeks in between every adjustment. So it may take a while until you get your final result. As I mentioned, irradiation is a contraindication, and the balloons have about 10% lower success rate than slings have. Now, if we look at the fixed retrourethral slings, mainly the advance, the implant is at the pelvic floor, so it is in part in the irradiation field. It supports the genuine sphincter. That means you need a genuine sphincter left, but you have a prompt result. You need a positive elevation test, and as we learned from the literature and people who use it a lot, it is not really suitable for severe incontinence. The success rate is lower when the patient has undergone irradiation therapy. Now, the adjustable slings, Atoms, Argus, Remix, they are suburethral slings. That means they are below the pelvic floor. They are out of the irradiation field. You can have a prompt result, or you have a secondary adjustable system like Atoms, but still you have a good result. There is the possibility of really exactly adjusting the retrograde leak point pressure. And from the literature, both for the Argus and the Atoms, there are publications who show that you may really use it also for severe incontinence. This comes to the point that I mentioned with the smooth muscle sphincter. You can put an adjustable sling right to 10 to 15 centimeters elevation of the urethral resistance. And that can be the reason for a high leakage, but you can treat it with a sling. Now, the negative points are there is a pain issue, definitely with the transobturator usage. The measurement of the retrograde leak point pressure is understood as a surgical challenge, or is not very liked by the colleagues. And of course, and you will need a good functioning detrusor for a sling like that. Now let's come to the hydraulic sphincters, mainly the AMS 800 or VICTO or Zephyr. Here we have really very reliable results. The treatment of severe incontinence and severely altered urethras and bladders is possible. You can combine the hydraulic sphincter with a stent, and you have a real physiologic open-close mechanism, and definitely you have a very high satisfaction rate. However, the patient has to be capable to use it. That means you have mental and manual limits, and in certain systems the costs may play a role. The AOS is about double of the most expensive adjustable sling. So the other way, now we know the good and the bad sides of the different implants. One very straightforward way to look which one to use is to see where is a good indication possible, but most important, what is a contraindication. And if you look at this slide, you can rule out very quickly certain implants in a specific patient. That means if there was too much previous surgery, you should not use a PROACT, or if there was a irradiation therapy, if the incontinence grade is too high, you might not use an advance, and so on. And if the patient is not able to use it, you don't use an AUS. You exactly know what I mean. This is a very quick way to rule out the contraindicated procedures. And once you have ruled out some of the procedures, you can use the diagnostic tools that I showed before to make your final decision what to use in a way together with the patient, as Emmanuel already mentioned, and find out what the specific needs would be. And for that, you use some special diagnostic tools that I mentioned before. So coming to a conclusion, I would say the guidelines that we have are really of very limited help for daily practice. And this is something that you cannot really use. The hydraulic sphincters have a high satisfaction rate, can be used in very complex indications and for redos. And the best way to go on is probably to pre-select upon the contraindications and ultimately determine by particular findings of the specific patient. And if I say specific patient, it is important to say that the specific needs of the patient must dominate the decision over a doctor's preference because he likes one method more than another one. And also the repertoire. In fact, this is the end of my presentation, but if you want to have the same thing or similar considerations in reading, I would recommend this paper in the EAU that we did together some years ago. And I think it is a very good thing to read when you are involved in male stress urinary incontinence. Thank you.
Thank you very much, Vax, for showing your experience and the wonderful presentation. So I know your patient selection is always based more on contraindications than indications, right? Yes, well, it is my first step. When I see a patient, very quickly I rule out. We have, as I mentioned, about 4 different approaches, and we offer all the 4 approaches that were mentioned. So my first way is to rule out 1 or 2 of these approaches, and then we go from there. Because I want to save my time and energy also with the diagnostics. And so it's always a little bit difficult to select the patients after radiotherapy, because you told us it is possible to implant an adjustable sling also after radiotherapy. I think this is absolutely correct. But do you think you should do a additional selection in these patients? Is it necessary to look a little bit deeper in these irradiated patients, or can you say in every irradiated patient, as long as the patient is not completely incontinent, an adjustable sling will be a good solution? Well, the irradiated patients, of course, have not the same outcome than patients without irradiation therapy. I have to tell the patient from the beginning, both if I look into a sling or an AUS. However, and also the AUS has not the same results in an irradiated patient like if there was no radiation therapy. We all know the patients who develop some calcifications, fibrotic changes behind the cuff
of the AUS in the area where the irradiation took place, and we sometimes have to even go back there and do some resection or take off the calcifications one way or the other. So also the AUS is not 100%, this doesn't come up with the same results in an irradiated patient. So when I have an irradiated patient, I know it will be a sling or an AUS. And the next step will be, can he interrupt his stream, yes or no? If he cannot, it will be an AUS. And can he use his hands to use a sphincter, and is he in the overall condition to use a sphincter? If it's not the case, then he will have a sling. So as I said before, the irradiated patients, I rule out the fixed sling and the balloon, and then the same decision making is like if it was not irradiated.
Just to make sure, if you talk about a sling, you talk about an adjustable sling, right?
Yes. If I talk about a sling, I usually talk about a retropubic adjustable suburethral sling.
Perfect. So Tanja, we have a question, right?
Yes, we have questions from the audience, and the question is, why do you see in contraindication proactive and the psycho?
Yes, very good question. Very good question. You really looked into the slide very carefully. Thank you for this question. It is an experience that I made over the years that the ProAct is a very good implant, but we have a 10% lower success rate than with other implants, and it takes a while to make it work, okay? And we have some patients who are so desperate that I'm looking for a quick result. This is the point. Of course, you can, if it depends on the way the patient sees his problem, but some of them are so desperate that I know I need the result quickly. Okay, so I would even go for a more invasive implant than the ProAct is, just to make it work in a certain time.
I think it's a really important question for the patient to ask, what is your main goal? To be really 100% continent, to be continent quick, or do you have a little bit time? Do you want to have low complications rates? So I think it's really important to discuss all of this with the patients.
Yeah, as we said, attitude and expectation plays a big role.
Yeah. Tanja, do we have another question at the moment?
No, at the moment not, but we have our vote again, if you want to proceed there.
So maybe I would like to ask our team here, because we have really great experts here, and I would like to know what is your definition of a mild, moderate, and severe incontinence, because I don't know it until now. So for severe is for me somebody who loses everything. Mild is for me somebody who loses some drops. But what is in between? What is moderate? I don't know what it is. So maybe somebody can answer this question for me. So Emmanuel, Roman, Wax.
Yes, I can comment. For sure, the severe incontinence is a patient who is unable to keep any urine in his bladder, definitively. But the patient who still leaks when he walks and who is doing no more sport, and if he does it, he will leak a lot. He is suffering severe incontinence because he has severe consequences on his everyday life. And when you ask patients about the activities they don't do anymore, sometimes you are surprised. So I don't have the feeling that severe is only not able to keep anything in the bladder. It's also not able to sustain any effort, whatever the type of effort. Even if sometimes these patients are able to store urine when they are sitting in a chair. So that is for me severe, and severe in terms of quantity of urine, and severe in terms of conditions where a patient can leak, like sports, exercise, and so. So I would ask the same for mild. What is mild?
Yeah. And Roman?
I completely agree with Emmanuel. We have to take also in consideration here, for example, in Czech Republic, some regulations. From a medical point of view, I completely agree with Emmanuel, but according to the regulations here, for example, the mild incontinence is up to 100 mils, moderate 1 to 300, and the severe incontinence more than 300 mils. So we have to take it into the consideration when we choose the method.
But there's my question: doing what? Sitting on a chair, 100 milliliters, or walking around, or playing tennis, or.
These are the results of the 24-hour bedweight test when the patient is performing the normal daily activities.
But there's the problem that a lot of incontinent patients really are really inactive, and so the really loss of urine we have no chance to evaluate it, because they don't act like a normal person.
This is the this is the important point, because this is also a point about sometimes adjustability, because we have patients, as you said, who are the couch potatoes because they're afraid of leaking. Then you do some improvement for them and you implant whatever implant, and then they change their attitude. They come back to their sports, they go to the golf course and so on. And it's nice if you have some adjustable device, because then the needs of the patient also really change. But to answer the question, I would also go academically, it is often 400 cc's per 24 hours, the cutoff, but 400 is really a lot. I would also go for the 300, up to 300, the moderate, and what is more than 300 is a severe incontinence. But as I said before, it is just as important to know the characteristics of the incontinence. Can he, as mentioned before, can he store something? Can he interrupt his stream? Is it the morning or the afternoon when he's leaking, and so on? But you are absolutely right. We are still not working with clear numbers here and clear criteria to find out what to do. That's why, as we already said before, it is always a specific decision to be made with every patient.
But the secret could be not only looking at the cc's the patient loses, but also the specialties of the incontinence, leaking during the night, in the afternoon, interrupting the stream, and so on. Okay, Tanja, so you have some questions at the moment?
No, at the moment, no. Just in this moment, one is coming in, so I will just tell you. Do you consider urodynamics necessary?
Question to me or to others?
I think it's
for everybody.
Yes, to everyone. I think.
So, Max, you have to start.
Well,
presentation.
It really depends on where you're working. If it's an academic institution, I think you should do urodynamics as often as you can. Urodynamics is also useful to let the patient know what he is looking at. If he had been incontinent for a long time and the bladder became small, I can make some urodynamics to let him know you might be dry, but you will have to go to pee every 2 hours, or things like that. Where I definitely need a detrusor function, in my opinion, is when I implant a sling, or especially an adjustable sling, because yes, we are raising the urethral resistance a little bit not very much, but a little bit, like I tend to say, like in a 40-50 gram prostate adenoma. But we don't want to put the guy in retention. That would be a mistake to do. So yes, I need to know that the RetroUrsal is working.
Yeah.
Right. We also have now another question, or do someone wants to add something?
Yes. In our center, we perform urodynamics in each patient. We perform about 15 to 25 patients a year. And what I would like to know from the urodynamics is the storage function of the bladder, which makes me possible to explain patients what are the chances for improvement. Yeah, it is known that the efficacy depends also on the bladder capacity. So if the patient has 200 mils or 400 mils, there are probably different expectations for the patient, especially right at the beginning after the procedure.
But do you often then change your opinion about the surgery? We actually changing devices after the urodynamics?
Actually, not much. Just it's mostly only about the expectation, and just to explain patients what are the chances.
And you start some medical treatment, some like anti-muscarinics or Botox or something like that?
Yes. In patients with very low capacity, we start with the anticholinergics.
Maybe I could mention that we do sometimes, if it is an AUS we implant, not with the other implants, maybe sometimes with an ProAct. But with an AUS, we sometimes do the Botox and the Sphincter implantation in one session. If we have urodynamics with a very small capacity bladder, we tend to do Botox in the same session.
So I really think that the main goal for the urodynamics is not to prove an incontinence or the continence status. It's more to evaluate the
RetroUrsal function
of the RetroUrsal function and the bladder function. Yeah. Okay, perfect. So Tanja, another question? If not?
Yes, there's another question from Professor Siracusano from Italy. And he is writing, in a patient with severe incontinence and underwent adjuvant radiotherapy, who developed a stenosis of the vesicle urethral anastomosis, what is the best solution in your experience?
So Vox, this is your question.
Is it my question?
Yeah, it is.
I would if he came to me now, I would, or maybe 2 weeks ago, I would tell him, I will get you nearly dry by Christmas, but now we have to do a big resection of the bladder neck. I talk with the patient and I do a resection of the bladder neck, but aggressively. All the questions about obstruction, also in the neurogenic patients, where you could use stents or you do a resection, always the de-obstruction is the bigger problem. Implanting an AUS for people who do it often is, as we know, not a big problem. But we need to de-obstruct him. So I would do an aggressive resection of the bladder neck. And if that does not work, I would probably put in a stent. But usually it works with an aggressive resection.
And how long do you wait between the resection and the sphincter implantation?
Well, I'm ungeduldig a little bit, as you know. No, it should be 2 to 3 months. That's why I talked about Christmas now.
And then before you implant the sphincter, you do a cystoscopic evaluation once again, and if it's wide enough, then you put in the sphincter.
Absolutely, yeah.
Perfect.